Now, next topic, management of epilepsy in children, Dr. V Murugan. This is also a sponsored topic, UCB India Private Limited. Dr. Murugan is a consultant pediatric neurologist at Chennai Children's Specialty Clinic, Global and Fortis Nagar Hospital. His special expertise is epilepsy in children, cerebral palsy, neurogenetic problems. He has done his basic medical graduation in Bangalore. Hello. And he has done his MRCP in 2000. Okay.
Good evening. Thank you very much for inviting me for the opportunity to give me this opportunity and UCB for giving this happen. The epilepsy in children is kind of totally different, so it starts kind of very simple conditions. It can be very complex also. And so what I'm going to talk about is a huge topic as part of pediatric neurology. So this lecture is going to give at least an overview on to see the different seizure types. Some of the videos I'm going to show it to you. And to have a concept of how to differentiate the epileptic and the non-epileptic seizures and what is the importance to that. And finally, as we understand more, knowing about epileptic syndrome is very important because the medicine we choose based on what epileptic syndrome the child is suffering from. And finally, understanding the concept of how a pediatric neurologist chooses a drug to treat the epilepsy and how many of them are available. And as I said, it's very much overview. At least we have a concept of epilepsy managing the children. So, what is it going to cover? Is it a seizure? Is a very key question any physician, treating physician should ask, particularly a child. And once it is a seizure, the next question should be, is this epilepsy? Because epilepsy only, you will start them on a long-term medications. You won't treat somebody on anticonvulsants just for one-off seizures. You have to wait at least the recurrent seizures before you coin the child as epilepsy. And the next one is what is the epilepsy syndrome. I will explain in detail what it is and why it is important. Then once you know, you made up your diagnosis, what you do next, and how you choose the drug. So, what I'm showing, three videos where if somebody wants to give the answer before I give the answer, you get a feel what it is. And I will tell the diagnosis and what the next thing to do for this patient. And this is very common. First month babies were brought to doctor by a lot of parents. And so if you get it wrong, you can do a lot of damage to the child in the sense where you need a reaction starting the medicine. So any answer? What is it? Any pediatricians here? So this is benign neonatal sleep myoclonus. Because the moment you say it is a seizure, it's very scary for a newborn baby's parents and the grandparents, everybody. It's a scary diagnosis. But that's why you have to diagnose it right, because this is a non-epileptic event which is happening, very commonly happening in a newborn child. Somebody who is up to 3 months of age, they can. Very characteristically it happens. The baby will not be disturbed from the sleep. It can jerk one limb, it can jerk all the 4 limbs. And the baby will not wake up from sleep. It will happen only in sleep. So, once you are a clinical diagnosis, you won't need to go for any further test or treatment. And this is a 10-month-old child. And who is doing about 50 times like this. And every day it's happening. So, if you are not seeing the video, you can imagine whatever way you like. It's a generalized seizure, generalized tonic-clonic seizure, you have just started medicine to EEG. So, how often you see, like even for me, I'm doing a pediatric neurology for 8 years, I have seen about 10 children. It is not common. but it can come anywhere from any kind of parents or any child. So it's a very growing up phenomenon. It is a non-epileptic seizure again. It's called shuddering attacks. So you don't need to treat them. So you can see the child is happy when doing these movements. So but it's a very frightening experience for the parents. So awareness about this condition is why it's very important. Already you got the answer. So one thing, a lot of time people give a history, they talk about jerking of the limbs. What happened before or after is very, very important when it comes to simple syncopal attacks. So this girl is doing a forced vasovagal maneuver, which is bringing out a syncopal attack on her. This is a medical student. So you can see the jerking is very obvious, where parents can come and tell it's a whole body jerking. You may take it as a history, it's generalized tonic-clonic seizures. Actually what she experiences is a simple faint. And in the simple faint, one can experience clonic movements like this lasting a few seconds up to a minute or two. But they immediately make good recovery. That is the key point. And somebody standing, somebody tired, somebody is not eating, those kind of predisposing history would be there. Again, you won't do any test except maybe ECG if there is a family history with that. Why? The long QT syndrome is one where they can have a recurrent vasovagal attacks or fainting attacks. So that is the only group of children or adult or anybody who would do investigations further on. So having seen three non-epileptic, then what is a true epileptic seizure? Basically it's originate from the brain. The seizure has to originate from the brain, not the external force giving the seizure. For example, typically you might have come across fever seizure, febrile convulsions. Nothing to do with the brain. The fever is irritating the brain is reacting to the temperature. It is not inherent from the brain. So that is not a true epilepsy. The same way breath holding spell in children. Lack of oxygen to the brain is reacting to that. The same way vasovagal attack, it is nothing to do with the brain. It is to do with the heart circulation. The circulation is compromised to the brain, it is reacting by these movements. So those are not true epileptic seizures. So what is true epileptic seizures? There is a abnormal electrical activity which is could be synchronized or very high voltage activity which is happening. The symptoms and signs are produced because of that. That is why a true epileptic seizure is. Now, what is epilepsy? It should be a recurrent epileptic seizures. Then only we call it as epilepsy. We don't call just one-off seizure as epilepsy. What is the relevance in children? 1 out of 100 children can have epilepsy in their life. And again, anyone can experience seizures. Up to 7% of the normal children can have one-off seizures in their life. So if we start treating everybody having seizures, we will be treating 7% of the normal children. So that is very important we make diagnosis beforehand, before starting the treatment. And the epilepsy is one where high disability is associated. More and more frequent seizures, it's going to affect their behavior, their educational performance, and their long-term outcome associated with that. Some children having a seizures in unexpected phase, they can injure themselves, and it could be a life-threatening situation also. And very key point is diagnosis of epilepsy is clinical. It is nothing to do with investigations. The investigations come into play to support your clinical suspicion. So it is on the background. It is not in the first test to do. And it's very, very important to have a correct diagnosis. Otherwise, a lot of times we overdiagnose and treat unnecessarily, or we may call somebody a psychiatric patient. Actually, that patient is experiencing seizures. Whenever things are not going according to your plan, that means we have to revise the diagnosis. You may call it epilepsy. You start the treatment, things are not improving, and revise and take a step backward and revise your diagnosis. Go through the history again if you need to get your opinion from someone else also. Same way, you started medicine, so much happening, too dramatic response, you're not convinced the way things are going, so that also you have to revise. So one of the other elements to epilepsy management, misdiagnosis is very common. In literature, up to 30% misdiagnosis have been reported in various papers. So when it comes to seizure types, there is two types. One is a generalized seizures, one is a focal seizures. In generalized seizures, it could be generalized tonic-clonic, and it could be tonic, absence, myoclonic, or infantile spasms, and atonic type. What it means, the seizure, when the seizure happens, the activity simultaneously starts from both hemispheres of the brain. That's what it means. So to have a generalized seizures, the both hemispheres of the brain is simultaneously involved at the onset. Then it is called generalized seizures. Why this is important to know? Because the drug we choose is based on is it involving both hemispheres or is it involving only one hemisphere at the start of the seizure. So if anybody can spot what you have seen 4 or 5 times I show, which side? Anybody want to shout again? What movement? We seen any abnormal movements, the boy demonstrating? On here?
Yes, sir. Not even more than
Yeah, so myoclonic. Myoclonic is very quick, it comes back to normal. It won't stay, the limb won't stay long. But the one I see commonly myoclonic epilepsy, they will experience 10 episodes, 20 episodes, sometimes 100 episodes a day. And that is where I have to aggressively treat them. And this is one of his demonstrating. But even some of us would experience it in sleep, early part of sleep, you get that. Then you go back to sleep normal. That is very normal physiological. But somebody is experiencing the awake phase multiple times, it may be epilepsy. So now, having identified the seizure, then I am convinced it is a myoclonic epilepsy, then I have to choose the drug. So that's how it works. Certain drugs work better, certain drugs make it worse. So you can see from the list the drugs to choose, the drug to avoid. So because we all familiar with phenytoin, so every neurologist prescribing it, I prescribe it, we make those seizure worse. So if it is a myoclonic, that's why identifying the right seizure is very important. Now, the next step, having identified the seizure type, is it epilepsy, or going for EEG. So what is the role of EEG? The role of EEG is to support your diagnosis. And once you are convinced it's a myoclonic seizure type, there is a wave pattern we see in myoclonic seizures, what's called polyspike wave pattern. Then I will be saying, okay, it's happened with myoclonic, I will follow. That is how you build up. In the same way, there are different types have different background EEGs, abnormalities. So that is how it helps. But can it be a normal EEG rule out a myoclonic epilepsy? Somebody is experiencing 10 myoclonic jerks a day. It won't. So that is where it is not confirmative test. So I have to be convinced it is a clinical seizure. I have to be convinced it's a recurrent. I make a diagnosis of epilepsy. I am just confirming the type of epilepsy syndrome. That is where I am using the EEG for. Just because he becomes normal, I won't stop treating this child. So that is how you have to make, and there are 50 different types. I am not going to tell every one of them, just to give you an overview of this. Okay, this is a everybody is familiar with this. I'm sure whenever we thought about epilepsy, we think about this only. So it's a classic generalized tonic-clonic seizure. You can see he is making the body stiff, then he is going for clonic movements, repeated rhythmic movements. So this is a generalized tonic-clonic. But the whole epilepsy, this represents only 50-60%. So you may see the 40% there is no clonic events or tonic events happening also. So they are also epilepsy. They need to be treated also. So this is how the EEG changes. It has a spike wave abnormality involving all the leads of the EEG leads. So involving both hemispheres. This is how they come. Generalized epileptic pattern. Very commonest group is idiopathic epilepsy. So how we choose the drug? There are a lot of now phenytoin can work here, and the other drugs are there on the list. But I think that is where the concept of we are so used to phenytoin, phenobarbital, a lot of people don't want to move to other drugs. I can tell you about, though we are running out of antibiotics, I can tell you we are not running out of antiepileptics. We got 15 antibiotics in the market which can do wonders for the patient. I have seen who are poorly treated or poorly controlled epilepsy. I'm just introducing one new drug and dramatic difference. Everything I've got, I'm just introducing a new drug, that's all. It is available in the market, almost every spectrum of drugs is available. It is available all over the world in India. So, and that is where, if something is not working, you have to think, is it another drug? Is it that we have to doubt our diagnosis also, which is not working. So, having talked about generalized seizures, next is partial seizures. As I mentioned earlier, partial seizures are the onset of the seizure. It is involving only one hemisphere only, because it could be a pathology involved. This is where the difference is. Generalized seizures, majority of them, there is no underlying brain pathology. That is mostly idiopathic. For a partial seizure to happen, a lot of time you may have a pathology underlying. And these are the group of patients neuroimaging is must. And how do you say, there is one group on the third line, second line, you can see focal arrow to generalized. A lot of time, it may not present as a focal seizure. When the parents witness the child, it would be a generalized seizure. The child might have had a one-sided jerking and suddenly spread to the other half of the brain and it became generalized. So this is where when we do the EEG, it is showing only one half only. Then we have to look for reasons. So that is where scan might show scan scarring or a brain tumor, or it could be any other pathology. So having seen a generalized tonic-clonic, you can see on this child, it's totally different movement you are going to see. So she starts deviating her eyes to the right. She starts deviating her head to the right. She lost her consciousness. You can see that. So this is the typical old terminology, complex partial seizure. But in current terminology, the terminology has been modified by International League Against Epilepsy. This is called focal temporal lobe epilepsy. So whichever part of the brain involved that comes into the diagnosis, and focal or generalized. Because complex is too complex basically. It's involving every partial seizure underneath. Because if you divide into the part of the brain and the treatment differs and the prognosis is also different. So now you have seen the list of drugs for generalized seizures. Now the list changes, you can see. Carbamazepine, levetiracetam, lamotrigine, sodium valproate, which is the top drug, it becomes on the lower end. Because for partial seizures, certain drugs were both better than sodium valproate. So I have seen a lot of physicians giving a trial of giving the sodium valproate. If it doesn't work, I will go to the next. I think what happens is its own side effects also there. So when you are convinced it's a partial seizure, it's better to go on other selected drugs. So same time may not do well if it is a partial seizure. Now there is another concept, something called epilepsy syndrome. So why this is important? Basically, this is not only seizure type. It happens, this type of seizure happens at this age. This kind of EEG changes should be there, and the seizure type will be different. So like that. For example, infantile spasm, very one of the common severe epilepsy in the first year of life. It will never happen in the after second years of life. That will happen only there. EEG changes is very characteristic. Same way, we are going to see another syndrome immediately, and there is a EEG PRC pattern attached to that. So there is so much classification based on the syndromes. So this is a classic absence epilepsy, and some children you can, in your clinic setting, you can make them to do hyperventilation. When they do that, and you can physically bring the seizures in front of you. So it has to be very forcible blowing. If they do it gently, it won't work. At least they should do it minimum 2 to 3 minutes. The lip smacking is called automatic, so that is part of the absence again. So they go blank, and then they return back to normal. And somebody can experience hundreds like this every day in absence epilepsy. So, time-wise, how much time?
Yes, sir.
Nearly.
Another 2 minutes.
Okay. Right. So, the typical absence epilepsy, you can see this is how, compared to the EEG you saw before, this is called 3 spike wave per second. and very classically they associate with childhood absence epilepsy. And once you know this background EEG and the pattern you saw in the video, then this is what the diagnosis is. Then you cannot choose the medications based on that. So the focal epilepsy is another, the temporal lobe epilepsy. I show the example. Some children can have pathology underneath, which is a mesial temporal sclerosis. Children who had long febrile convulsion in younger age can develop this, and they are very resistant to drugs. Sometimes they may end up having operated epilepsy surgery for this. And this is, the child was born like this, so this is a normal size brain. You can see it is a totally onion feeling appearance pattern. So this is a cortical dysplasia. So while operating, this issues can be better controlled. So what to do? I think in epilepsy, if you are not sure about the diagnosis, not necessarily you should tell the patients. You should ask them to wait, ask them to record, make them to note down the events, ask them to come back. I think it's better to wait and watch rather than jump and start the treatment. Because once we start that, it confuses the picture for the doctors, for the patients, what's going to happen next. And in terms of investigation, EEG, neuroimaging, and if we can refer to pediatric neurologists and they're not sure that is option for you. And when it comes to treatment, and there are multiple reasons why we should treat them. Main thing is to prevent further seizures and status. And sodium valproate, carbamazepine are well-known drugs, and in the market we have broad-spectrum drugs and narrow-spectrum drugs. And the narrow-spectrum drugs, particularly for partial seizures, the broad-spectrum can be used on both. Finally, just cases if you come across where in the home treatment, intranasal midazolam patients can hold on to them. They can use it at home even before coming to the hospital. The old one is the dextron is less and less used. Somebody reaches the hospital, IV lorazepam is the best thing to do first step. If not, IM midazolam can be given also. And the next one is phenytoin. Phosphenetine is advantage. You can give us intramuscular also. Same dose, but it can give us a bolus injection. And phenobarbital is the next one. And these two drugs not working, then you have the option of going for IV levetiracetam or sodium valproate. And those three were not working, you can go for IV midazolam infusion. Sodium is up to 500 micrograms. And definitely this is the time to transfer the patient to nearest intensive care. Of all the important management status, we should remember always ABC, because patient will be killed because of lack of oxygen, lack of circulation time because of the seizure. So the first step is any seizing patient coming in front of you, make sure you maintain the adequate breathing circulation. Then only looking for the drug.